Dr. Tara Rastin is a clinical assistant professor of neurology at University of British Columbia and movement disorders specialist at the Pacific Parkinson's Research Centre. She completed her undergraduate medical degree neurology residency and 2-year movement disorders fellowship program supervised by Dr. Anthony Lang at the University of Toronto between 2007 and 2018. And she has been practicing in Vancouver, BC since August 2018. She's a clinician and educator with specific interests in providing movement disorders related teaching to the UBC Neurology Residency Program, as well as contributing towards strategies to meet the clinical challenges of delivering care to our patients with Parkinson's disease in BC. Dr. Rastin, welcome and thank you for presenting for us today, and I will pass it over to you now.
Thank you, Alana, for the introduction. Hi, everyone. I'm Tara Rastin. I'm a movement disorders neurologist here in Vancouver, BC, and I'm really happy to be here today talking to you about one of the advanced therapies available for Parkinson's disease, which is called Duodopa. If you have questions, please type them in the chat box, and at the end I'll answer them, or if it's fits in with that slide, I'll answer it right there. Just my disclosures, which are basically nothing to disclose. Today we'll start with this general flow. During the talk we'll go through these questions, and the first half of it is really related to, well, what is Parkinson's disease and what are its symptoms and how it's treated. We'll go through these slides a little bit more quickly because you're probably already familiar with a lot of these topics if you're attending a webinar about Duodopa, but we need some background information to explain Duodopa later. And then the second half will focus on, well, what are the advanced therapies for Parkinson's disease and when are they indicated? And then specifically, we're going to focus on Duodopa, which is basically a continuous intestinal gel of Levodopa. Duodopa is the trade name. So during the talk, you might see that I refer to it as Lcig, and these two are the same things. And then, the question of well, is Lcig right for me? Is it going to help me if I have Parkinson's disease, and what the basic process is to get it started? And then at the end, we'll have about 15 minutes to have a question and answer period. So to begin with, Parkinson's disease, as you all likely are familiar with, but briefly, is a brain disease, a neurodegenerative condition where it is primarily characterized by loss of dopamine-producing cells and also accumulation of specific type of protein within brain cells, which create little basically accumulations or aggregates called Lewy bodies. So if you kind of break that down in plain speaking terms, neuro meaning there's a brain disorder, degenerative meaning that there is a slow progression, and specifically in Parkinson's disease, it's over years and decades. There's a loss of dopamine and the accumulation of a specific protein, alpha-synuclein. Parkinson's disease is the second most common neurodegenerative disorder after Alzheimer's disease, and we have about 100,000 Canadian patients with Parkinson's disease, about 13,000 in British Columbia. So what are the symptoms of Parkinson's disease? I think what's really important to know is that the symptoms are very variable. So if you were to read any general literature about Parkinson's disease symptoms, you will see that there's a whole possible list of symptoms, and that can be overwhelming because that's such a long list. We're going to talk about these today a little bit and to break them down, but it's really important to know that one individual does not necessarily develop or experience all the possible symptoms, but there are different types of symptoms possible, and people have different experiences of Parkinson's disease, in part because of the variability and the different types of symptoms that are possible in each person. Also, symptoms within one individual also change over time. Okay? So broadly speaking, we can break down the symptoms into what we call motor symptoms and non-motor symptoms. By motor symptoms, I mean the more visible aspects of Parkinson's disease. And the hallmark of Parkinson's disease is really a slowness of movement, which we call bradykinesia as its technical term, but essentially a slowness of movement and the difficulty with fluidity of movements. The other motor symptoms that are common are a stiffness or rigidity, sometimes but not always, resting tremors, so tremor of a limb that is not really in motion at the time, so either when a hand that's resting in a lap, for instance, or a hand that's dangling while walking, or a leg while seated, etc. And this slowness of movement, this bradykinesia that is the hallmark of Parkinson's disease, can manifest in various ways. So, and these come out in the various different kinds of symptoms that we talk about in Parkinson's disease. For example, decreased arm swing when walking. So, so some patients or their families notice as one of the very first things that there's a change in how the person walks because they're not swinging their arm very well, or they're not swinging their leg very well, their stride when walking. There can be a change in handwriting, decreased dexterity with very manual hobbies such as knitting or drawing, applying makeup, etc. Reduced facial expression, so a flatness of the expression, that's because there's less movement in the facial muscles, and changes in speech, so softer speech, less clear speech, again, because there is slowness of movement in the muscles that help you produce speech, etc. So these are the motor symptoms, and they can affect different parts of the body, not necessarily all parts of the body in each patient. Different patients experience different things. This is what I would call the more visible part of Parkinson's disease because we can see movement, and often treatment can be quite focused on these aspects that are very visible. However, it's important to also recognize that in Parkinson's disease we can have a whole bunch of what we call non-motor symptoms. What I mean by these, again, this is a long list, and this does not necessarily mean that any person who has Parkinson's disease will necessarily experience all of the things down this list, but they may experience a number of these. And these non-motor symptoms, which are less visible unless we ask about them, are things like constipation or sleep disturbance or sleep disorders, fatigue, mood disorders, feeling either quite anxious or experiencing low mood or depression, or things such as control of bodily functions like bladder control, or drop in blood pressure when standing, or with rapid postural changes like going from lying down to standing, or cognitive changes, for example. And among that as well, pain, although pain is a common symptom in a whole bunch of different diseases, and which can overlap with Parkinson's disease. So not all pain is related to Parkinson's disease, but in Parkinson's disease, you can sometimes experience pain, although many patients would say that pain is not a part of their experience of Parkinson's disease. So these are all the possible non-motor symptoms of Parkinson's disease, or at least many of them. So how do we treat all of these different symptoms? And I'll come back to why I've made the distinction of motor and non-motor symptoms and in the next few slides. So currently, we do not have curative treatments yet. However, Many symptoms, whether they're motor or non-motor, can be controlled with a combination of medications as well as regular exercise. Today, we're not really going to focus on the physical therapy or exercise portion of treatment of Parkinson's disease-related symptoms, but it is really important. We're going to focus on kind of medication therapies. And so many of these medication therapies typically aim to replace dopamine, which, as I had mentioned earlier, is one of the things that is lost in the brain that has Parkinson's disease. Now, an important note is that while some of the non-motor symptoms respond to dopamine-related therapy, many do not and should be treated separately in conjunction. So, for example, constipation isn't necessarily going to be improved by replacing dopamine. And so it should be treated the way we normally would treat constipation of other causes. Or mood disorders. So many patients who have significant anxiety or low mood should seek treatment for that, either through a counseling or medication specifically for mood disorder, or a combination of both, etc. Okay. Now, in order to talk about Duodopa or Lcig, we need to talk about Levodopa more, okay? Because Lcig is essentially a continuous gel infusion of Levodopa. So Levodopa carbidopa was a major breakthrough in the symptomatic treatment of Parkinson's disease back in the 60s. And so we've had experience with this drug for quite some time now, close to 60 years now or more. Levodopa is converted to dopamine in the brain. So levodopa is absorbed into the bloodstream. It can cross from the bloodstream into the brain. And it can cross what we call the blood-brain barrier. And once it's crossed the blood-brain barrier, it can be converted to dopamine to be used in the brain. Okay? Now, all carbidopa is a second drug packaged along with levodopa to prevent conversion of dopamine outside of the brain. So, in the gut or other places that your blood can go to in the body, to reduce or avoid side effects such as nausea and low blood pressure, which would occur at a much higher rate if the levodopa wasn't packaged with the carbidopa. Now, levodopa remains the most effective or potent medication, like pharmacotherapy, available in the treatment of Parkinson's disease today. And because of that, everyone with Parkinson's disease eventually requires levodopa, although very early in disease, symptoms may be controlled with other agents alone, and certainly along the way, other agents may be used in combination with levodopa in order to manage symptoms as best as possible. So a little bit more about levodopa. So this is where this is a very crucial concept, I would say, in understanding whether Lcig or Duodopa is right for a patient, is to understand that some symptoms, but not all symptoms, improve with levodopa. The symptoms that improve with levodopa are called levodopa responsive symptoms. And while these are often motor symptoms, such as stiffness or slowness of movement, that bradykinesia that I talked about earlier, tremor, all of those visible parts of Parkinson's disease, many of them, although not necessarily all, but many of them tend to be levodopa responsive. It's also important to recognize that some non-motor symptoms also are levodopa responsive. For example, certain types of pain, sweating that's episodic, for instance, episodic anxiety, so not a baseline anxious or low mood state, but very episodic anxiety, bladder urgency, etc. Now, in the very beginning, so when symptoms are quite mild, or in the earlier stages of Parkinson's disease, when levodopa is started, patients initially experience what we call a long duration effect. And what I mean by that is that there's an overall improvement noted after days or weeks of taking the levodopa. And there's no worsening really noted if the odd dose is missed. But again, if the medication is stopped or reduced after several days or weeks, there is a clear worsening in the symptoms again. As disease progresses, patients become more aware of what we call a dose-dependent response. So symptoms improve and then return with each dose of medication. Initially, it might be every 6, 7, 8 hours, maybe 4 hours, but over time, that interval of how many hours, the duration of effect of levodopa tightens over time. I would say that the concept of off periods is really important to understand because it probably will come up often when you speak to your healthcare providers. And the reason for that is that if there are frequent off periods, adjustment of medications may be able to improve your quality of life, and that's why often healthcare providers might be, interested or asking you about so-called off periods. And what we mean by off periods are times when medication effects, so the levodopa effects, have worn off and symptoms return. So symptoms that you experience in your Parkinson's disease that normally respond to the levodopa have now returned. Those times are called off periods. The term motor fluctuations, people sometimes define slightly differently, but essentially they're referring to a stage where there's frequent cycling between on and off periods, and there may be presence of bothersome dyskinesias as well. And so we're going to talk more about dyskinesias on the next slide. So with increased duration of disease, again, typically not in the very early stages of disease, but in the mid to later stages of disease, patients can begin to experience what we call levodopa-induced dyskinesias. And these are periods of excess rocking or writhing movements that correlate in time with doses of levodopa, and most typically at the time when levodopa is having actually good effect. So at the opposite time of off periods. So not when the medication effects have worn off, but typically at the peak of the medication effects. And this can be really hard to explain just in words, so I thought that a video would be really helpful to kind of show what I mean by the word dyskinesia. And because this is a recorded and publicly available webinar, I don't have personal patient videos to show, obviously, for this, and in order to not infringe on copyright or patient confidentiality, I thought it might be helpful to watch a really short YouTube clip of an interview with Michael J. Fox by George Stroumboulopoulos. So give me one moment just to bring up that video. Just gonna bring it up to the time that I think we should start watching.
It's easy for me.
You have a real sense of humor about Parkinson's and the way you present it publicly. The Curb Your Enthusiasm stuff was unbelievable.
Oh, thanks. Oh, Jesus Christ! What the hell?
What?
Did you shake that up on purpose?
Parkinson's. When Larry called me up, and I don't know Larry that well, I've met him a few times, but he called me up and asked me if I'd do it and pitched the concept to me, and I said, this is great. Because the way they work on that show is they, there's an idea, there's a series of points you want to get to in the scene, but how you get there is up to you.
Yeah.
So as you're watching this short clip, I like that clip because it shows a bit of humor about Parkinson, and it showcases work that Michael J. Fox has done on TV that brings up Michael brings up Parkinson's disease. But as you watch Michael J. Fox speak to George Strongolopoulos, you might notice that he has some turning of his neck to the left and right, or some excess movements of his trunk or his hands as he's speaking.
It's all ad lib. It's all improv, and it was just great for me because I don't get a chance to do that much.
And that's what I mean by dyskinesia. So I'm just going to switch back to the slides and we'll talk about this a little bit more. So you can see from that video that actually, while he's having the dyskinesia, and the dyskinesias that we saw in that particular video clip are what I would call mild, maybe mild to moderate, but they're not particularly severe. They're not interfering with his ability to do what he wants to do. He's able to speak well. And his facial expression is quite good. So actually, he's not experiencing an off period. He's not having bad tremor. His voice is strong. He's able to move his limbs well, but he has a bit of excess rocking, writhing movement. And that's what we mean by dyskinesia. Okay. Now, I'm not going to spend a lot of time on this during this talk because we have a different focus, but our current understanding is that dyskinesia correlate best with the disease duration as well as higher individual doses of levodopa, so creating peaks of levodopa concentration in the bloodstream rather than accumulated levodopa exposure or the number of years that someone spends on levodopa itself. And so what I've kind of talked about over the last two slides is that initially there is this long duration effect where even if you miss a dose, you might not really feel a big difference in your body, but later on you feel this dose-dependent response where you might be able to describe when you feel on or off. And sometimes when you're on, you might be aware, or others around you might be aware of excess movements that we call dyskinesia. And as disease becomes more advanced, off periods and severe dyskinesia can alternate as levodopa blood levels rise and fall. And this slide demonstrates what I mean by that. So in the early part of disease, there's a really wide, what we call therapeutic window. So regardless of how the levodopa levels are rising and falling in the bloodstream, in the plasma concentrations, there is this nice wide therapeutic window where the patient feels well, isn't really experiencing dyskinesia, isn't experiencing off periods, okay? With moderate disease, let's say, there might be some dyskinesia at the peaks and some small periods where symptoms return that we call off periods because that window has narrowed a little bit. In advanced disease, there's a frequent cycling between either feeling really off or being quite dyskinetic, and in general spending more time being off than in this nice on window. And that's what we call advanced Parkinson's disease, when there is this narrow window where the body or the brain becomes very sensitive to different levels of levodopa in the blood, and you're trying to really keep the levodopa in quite a small concentration range in the bloodstream to keep things even. And so this is really more a summary slide about therapies for advanced Parkinson's disease, and the point of this slide is really to say that when there's advanced Parkinson's disease, when we're in this stage, right, where there are frequent on and off periods, there's severe dyskinesia, there are two main advanced therapies. One of them is surgical or deep brain stimulation. That's not the focus of this webinar, so I won't be talking more about it today. The other is the focus of our webinar, which is about levodopa continuous gel, intestinal gel, sorry, that's a mistake there, intestinal gel infusion or Duodopa. Now, this, for obvious reasons, Duodopa is only going to work well for symptoms that respond well to levodopa because it is levodopa itself. It is used when there is frequent wearing off or severe dyskinesia, and these are interfering with the quality of life. In general, cognitive impairment is less of a concern in the use of Duodopa than in deep brain stimulation. But I would say that the presence of a care partner for a patient who is using Duodopa is really, really important. Now we're going to kind of focus more on the details of levodopa, carbidopa, intestinal gel, or Lcig or Duodopa. So as I've mentioned, it's used in the treatment of advanced Parkinson's disease. It's not useful in sort of mild or moderate disease states. And what I mean by advanced Parkinson's disease is where there are frequent off periods in spite of maximal or optimized oral therapies. A good levodopa response is a prerequisite or necessary before anyone would be eligible for Duodopa, because Duodopa is just levodopa itself. It's the delivery system that is different. And so levodopa unresponsive symptoms will not improve with Lcig. So how does Lcig work? And I think this picture kind of shows you a good image of what the delivery system is. And actually, on this previous slide, you can see that there's a tube that runs and sits, the tip of it sits in the small intestine, okay? And in this slide, we can't see that because it's in the person. So there's a tube called a PEG-J tube that's placed through the stomach wall, and its tip lies in the small intestine. The other side of it comes out through the abdominal wall, and there's this segment of tube that is hanging outside. Now, that segment of tube can be connected to a pump. So this is a pump, and cassettes that contain levodopa gel, which is this part where my mouse is hovering over, can be connected to that pump. And that sets up a system so that levodopa can be pumped at a set and constant rate into the small intestine. So instead of taking a set amount of pills every 3 hours or 2 hours or 1.5 hours or a pill every hour, what happens is this pump is delivering a small dose that is continuous throughout the waking day. So the benefits then of Lcig that it could provide in the right patient is that it stabilizes the levodopa concentrations in the bloodstream to stay within that narrowed therapeutic window that we were talking about earlier on this slide. So it helps deliver a constant rate that hopefully you titrate it so that you find this rate that is just inside this window and trying to deliver as much constancy as possible to help the patient stay within a window where they don't have bothersome dyskinesia and they don't have off time. So the idea would be more on time, less off time, and reducing the amount of time where there's violent or severe dyskinesia that's interfering with the quality of life. The other possible benefit is that it bypasses the stomach. And in many patients with Parkinson's disease, there can be delayed or slowed gastric emptying. So when a pill is taken or a couple of pills are taken, they sit in the stomach for quite some time before passing on into the small intestine where levodopa is absorbed. And that may either make it, cause a really erratic response to individual doses of levodopa. It may basically mean that you feel that you took a set of pills and they didn't work at all, what we call dose failures. And the idea behind this sort of continuous gel infusion right into the small intestine is to bypass that problem. So then the question is, well, is LCIG right for me? I have Parkinson's disease and I have some of these more advanced symptoms. Is it right for me? The first question is really, are there levodopa responsive symptoms, but way too much wearing off or bothersome dyskinesia? So are you spending a lot of the day either on or off and unable to find that sweet spot, but you know that actually there are times when there's a sweet spot? And has everything been done to optimize oral medications? Because if you're spending a lot of time with off symptoms, but you're only taking, levodopa 2 or 3 times a day, then, often that means that medications can be optimized orally without resorting to a PEG-J tube. Now, that does mean that LCIG does not improve symptoms that are not levodopa responsive. And the other thing that this means is that either the patient or the care partner together need to be able to very reliably report to your healthcare professional the off periods and the dyskinetic periods. So you need to be able to report a fairly accurate sense of what symptoms you're experiencing when you don't feel well. Are they off periods or are they dyskinesia? And when they're occurring in relation to your medication timing. And sometimes what we call symptom diaries are really helpful to track that, and I'll show an example of that on the next slide. The next question is, are there any reasons that make it either unsafe or impossible or basically not a good idea to place a PEG-J tube? And the main person who would really answer part of this question would be the GI specialist. But another thing to consider is the patient actually himself or herself wanting the PEG-J tube and also able to keep it there and not fiddle with it or pull it out. So examples of where a situation that might prevent that would be in a patient who has psychosis or severe agitation and or significant cognitive impairment, so that he or she might pull the tube out without intending to or intending. But other things that can make this tricky would be things like previous abdominal surgery or previous serious intra-abdominal infections, etc. Patients who are on blood thinners, for example, for an irregular heart rate like atrial fibrillation, aren't necessarily excluded from having the PEG-J tube, but the GI specialist needs to be aware. And the timing of the blood thinners will need to be coordinated with the placement of the PEG-J tube. Now, another really big thing is patient preference. So it really comes down to what you want for yourself. And for some patients, the appearance of having a PEG-J tube or the necessary daily care that goes into it might make you think that this isn't for me. Or the idea of having a pump that you need to carry around. There's different, on this slide I show a fanny pack that many patients use, but there's different ways of carrying them around. There's also a vest, for example, that people can wear that contain the pump. And it gives you a good idea of how big the pump is. It's about 3 pounds, and you end up carrying this around the whole time that you're awake. So typically around 16 hours a day. Occasionally, patients with Duodopa go on 24-hourly Duodopa even while they're sleeping. And again, having that pump connected to you while you're sleeping is another consideration. Again, all of this is very manageable in the patients where you feel that this is helping your quality of life. But for some patients, these things are important and a barrier to actually wanting LCIG. The other practical considerations are that is that there is a lot of day-to-day care that goes into using Duodopa. So connecting the pump in the mornings, being able to give yourself a boost or an extra dose if you're coming off, for instance, being able to disconnect and do the proper tube care and pump care at the end of the day, doing proper stoma care, so the site at which the tube goes in and out of the body, keeping that clean and uninfected. And typically, given the stage at which patients need or are appropriate for LCIG, I think that in our experience, having an engaged care partner, typically someone who's living with you, who can help you connect in the morning if you're off and not really dexterous, helping record problems so that you can remember them to report back to your doctor. That I found has been really, really important in successful maintenance of LCIG. The other things are, is there local GI care? And is there a local healthcare professional who's willing and able to provide basic assessments or basic stoma care, physically make pump adjustments? And really what this comes down to is your distance from the tertiary care center that's providing the LCIG titration or expertise, and the costs associated with that, and how far are you in your ability to travel, basically. So here is an example of a symptom diary, and up here it kind of lays out for you what we mean by plus numbers 0 and minus numbers. So 0 is that sweet spot, is that narrow therapeutic window where you feel good, you feel on without symptoms, but also without dyskinesia. A 1 plus are mild dyskinesia, so visible small extra movements, but really small and maybe not even all the time. 2 plus are clear extra movements, moving continuously at rest. 3 are really, big extra movements that are interfering with, like sitting still in a chair, making you slide off a chair, for instance. So in that video on YouTube, in the interview that we saw with Michael J. Fox, he was probably having like a +1.5, right? And then on the opposite side, the negative numbers, meaning that you feel off. So you feel that there's a return of your symptoms, whether that's tremor or feeling really rigid or unable to move well, unable to speak well, etc. And again, 1 being the least, very mild off, and -3 being very severe off. So here we have a patient who's tracked the time that they took a dose. So each of these boxes represents an hour. So this is like 6 a.m., this is 9 a.m., etc. They've tracked the time of their dosing, and then they've tracked whether they feel like mildly off. Here they feel in that sweet spot, but then the late morning to noon, they start to go off and have a severe off, and then they take a set of pills, you can see, and they have a period where there is mild to moderate dyskinesia, and then it goes back into a good on state again. And so this is an example of a symptom diary, and this is an example of the type of level of communication and insight into your understanding of what dyskinesia is, what your off feels like, and being able to kind of communicate that, and also being able to track when medications were taken. And this kind of communication is really necessary for your healthcare providers to be able to, first of all, tell you whether you're eligible for LCIG, but secondly, to help make LCIG a success if you are eligible. So a little bit about the basic process to starting LCIG, and this then would be my last slide, and we'll take questions right after this. So First of all, you need to have an evaluation by a movement disorder specialist at a center offering LCIG. So in BC right now, that would include Vancouver or in Kelowna for the patients within that catchment. Those are the two places that I'm aware of right now that are initiating Duodopa. There are other sites where they do have expertise in Duodopa, so they're not initiating, but once the patients are initiated, they're providing the care going forward. And obviously this will change over time. If you are eligible for LCIG, then the general next steps are that you're referred to an AbbVie education program just to provide information, to provide education about it, to answer questions about what a pump looks like or feels like, etc. And so an AbbVie community resource nurse can actually come to your home and provide education about what the pump looks like and what it's like to carry it, or what the different carrying devices are, and how heavy it feels, etc. A referral to a GI specialist needs to be made to actually book the procedure to place the PEG-J tube. And typically this is a day procedure, so typically you go home the same day. And then there are slightly different approaches to the initial titration of Duodopa in different centers. There isn't one specific protocol that all centers follow, but many centers do what's an outpatient titration very successfully. My understanding is that most centers in Canada do an outpatient titration, which we also do at our center. And generally this means that 2 to 4 weeks after the PEG-J placement, sometimes maybe slightly longer if the patient is experiencing more pain or if it was a difficult placement. There's an outpatient titration over 3 to 4 days at our clinic, basically. And what those days look like are that basically from approximately 8 to 9 a.m. to about 4:30 p.m., you're at our center with one of our nurses, maybe more than one of the nurses, three to 4 days in a row. And so it's really obvious then that a care partner is really necessary to be in attendance for support, for the travel that, for the day and at the end of the day, and also for the care partner to get more education on what to expect and how to use the pump, etc., how to do cleaning of the stoma site, etc. And our physician is in close communication with the nursing to find an appropriate rate of infusion during those few days. And obviously during these few days, there's lots of education regarding the pump, regarding stoma care, etc. And again, at our center, our process is that usually after 2 weeks, so at the conclusion of the titration, we schedule an in-person appointment again in 2 weeks just to make sure that things are going as expected, or to make sure that further adjustments aren't necessary. Following that, the appointments become again more routine, like every 6 months or so, to just the way it was when you were on oral medications. Okay, so those are my slides, and I think that there's been a number of questions, so I'll go to the question, and I'll just start from the top. So Mike asked if erectile dysfunction is a non-motor symptom, and the answer is that yes, it can be, but erectile dysfunction can obviously occur outside of Parkinson's disease, so you need to speak to your family doctor and then your neurologist to see if it's the Parkinson's disease or something else and how you would treat it. And I would say that typically erectile dysfunction may be something that requires more than Levodopa to treat. If there is ongoing mood issues, that can obviously be a huge impact on erectile dysfunction. So another thing to consider is sometimes that there's actually an anxiety or mood disorder that needs to be treated. Susanna asked, can anything be done about PISA syndrome? And so that's a broad question. It's difficult to answer very briefly, but I think the answer is sort of yes and no. So often very midline symptoms in the body, so whether it's PISA syndrome or very hypophonic speech, so lots of difficulties with speech or swallowing, can be more resistant to levodopa than others. Okay, so sometimes truncal kind of tilt, which is what PISA syndrome is, so leaning to one side like the Tower of Pisa, may not respond very well to levodopa at all. And given that, you typically would not expect it to respond to things like Lcig duodopa or DBS. However, another thing to know about PISA syndrome is that this can be seen particularly with use of dopamine agonists, which we did not discuss today because that's not really part of the webinar topic today, but one thing to consider is that sometimes transitioning off of a dopamine agonist and going on to something else, an alternative like levodopa itself, might be the answer. Again, this is a bit of a complicated question to answer very specifically, so it would be good to speak to your doctor about that. Is dystonia a motor symptom? That's a question from Allison, and absolutely yes. And so what we mean by dystonia is stiffness that leads to an abnormal posture of a limb, usually can be of the neck or the jaw, etc. And it's not really completely fixed. There's some mobility, but there's generally a tightening and a adoption of an abnormal posture. And sometimes it can cause kind of repetitive movements, but often just an abnormal posture. And yes, dystonia is most often what we call an off symptom. So like resting tremor or slowness of movement, that bradykinesia, dystonia is often very uncomfortable for patients and usually a sign that this is an off period. In rare cases, you can have an on dystonia. And again, not rare, but much less common cases, you can have dystonia at the peak of levodopa effect. And ultimately, the way to figure it out is to track when dystonia is occurring in relation to when levodopa is being. Susanna asks, what if levocarb is no longer working? What are other options? I think that's a really broad question. I think that that's a little bit difficult to answer without more context. There are symptoms, as disease really progresses, there are symptoms that are difficult to address. But the other thing to recognize is that depending on the type of symptom being experienced, the answer may not be levocarb in general. So if levocarb isn't working, for example, for a mood disorder or chronic pain, the answer is to treat those things separately, like you would treat chronic pain in other situations, or mood or anxiety in other situations, etc. Now, and I also think it's important to say here that deep brain stimulation and duodopa are not replacements for symptoms that are not levodopa responsive. Carol asks, is there a maximum dose of levodopa? And the answer is there is no one maximal dose of levodopa. So there isn't one dose where beyond that it's toxic. what is the individual's maximal dose of levodopa is the dose at which they start to experience unwanted side effects. And so that becomes, so for example, with disease progression and with higher doses of levodopa, sometimes patients feel very lightheaded or faint. That's just one example of a side effect. And so that might be, in that individual, whatever dose is doing that tells us that that's the cap that we shouldn't push past in that patient, at least for the individual dose, and you back off and go to a next lower dose that is tolerated. Sometimes the answer is to reduce the actual individual doses and to just give smaller, more frequent doses over the course of the day. Obviously, that becomes really disruptive once you're taking medications every 2 hours or an hour. And essentially, that's one of the places where LCIG might be helpful, because essentially it's giving a continuous delivery of it. Hugh asks, exercise, particularly when vigorous, can result in production of dopamine, or so I think. What is the relation of production of dopamine in this manner to doses of levodopa available on the daily schedule of medications designed to keep levels available to us constantly throughout the day? Yeah, that's a really interesting question, Hugh. So one of the problems in Parkinson's disease is that the brain loses its ability to produce or release dopamine, And so, exercise isn't necessarily going to release enough dopamine in a patient with Parkinson's disease for us to allow to not take medication that day because you exercise. We don't fully understand why regular physical activity is so beneficial to controlling the symptoms of Parkinson's disease. We do understand that the regularity of physical activity is important. So the benefits of physical activity are short-lived, and that's why it needs to be regular. But speaking practically, usually vigorous exercise doesn't mean that on day X, if you did vigorous exercise, you could cut your levodopa, by 1 tablet or 2 tablets or something like that. In fact, some patients, many patients, in fact, might notice that when they do strenuous activity or vigorous activity, that they actually have a shorter duration of effect of their levodopa. And patients will come and say, it feels like I'm burning through the dose faster when I do right after my really vigorous period of activity. So what's in the end important is to simply find a dosing regimen throughout the day that works to allow you to do the activities, your daily activities that you want to do. And another thing that's probably important is to try to create some sort of regularity about your dosing schedule, and taking things relatively on time and in a consistent basis. I hope that answers your question. We have 5 or 6 more minutes, so I'll try to answer the rest of the questions. I don't think we have too many, so I'll try to answer them. And Allison has a few, so actually Ben and Allison are the only other people with questions right now, so I'll answer Ben's first. It's 1 question, and Allison has a few of them, so I'll group them together. So Ben, your question was, do you continue taking Sinemet with LCIG? That's a really great question. And the answer is generally not. What we do is we calculate your total daily dose before the titration of the oral amount of levodopa or other medications like dopamine agonists like pramipexole or latigatine, etc., that you were taking. And we kind of add it up and we do a very rough conversion or equivalency to LCIG dosing. And that's the starting point for how we titrate. So on day 1 of your titration, before we've done any titration, that's how we ballpark guess what rate do we start at. And then over the next 3 days, we watch how things are going, whether there's too many off periods or there's too much dyskinesia, and then we adjust the rate over the next few days to find that sweet spot that's helpful for that patient. So ideally, at the end of the Duodopa titration, you don't take any more oral Levodopa or dopamine agonist, ideally, or other oral medications that are related to Levodopa, like entacapone. Sometimes patients do take some Levodopa overnight because they disconnect their pump at the end of the evening to go to bed, and they might take also a dose of a Cinemet or a Cinemet controlled release to kind of give them a little bit of dopamine throughout the night. Now, Allison's questions, we have a few minutes for them. So first of all, can you keep taking rasagiline with Lcig? Yes, there's nothing stopping you from doing that, but there's generally no need for it. Stopping the rasagiline after someone's on Duodopa generally doesn't create any difference in their experience, so most people would want to stop taking rasagiline. By the time someone is having severe enough symptoms that they qualify for Lcig, they are not finding that rasagiline, whether you add it or remove it at that point, is really making a difference. Can it be used 24 hours if the patient is very still during sleep? So yes, there are instances when Lcig is used 24 hours. Generally, we don't start there because it is, inconvenient to have a pump attached to you while you're sleeping. And also you do end up using a lot more Duodopa that you might not need if we started at 24 hours. In certain specific situations, we convert to 24 hours. That's usually in two cases. One, if, like you've said, there's a lot of bothersome bradykinesia or stiffness overnight, and the patient just can't get through the night. That would be one reason. Usually that's not the case because during sleep, people just generally need less dopamine than during their waking hours. The other situation where we might use that is sometimes after the pump is disconnected, patients experience a prolonged period, like an hour or more than that, of very bothersome dyskinesia as the concentration of levodopa in their bloodstream drops or changes, and because that dyskinesia is not manageable in any other way, in some situations we convert to 24-hour Lcig for that situation. Allison's other two questions. Does one neurologist have to refer you to a movement disorder specialist? What if they don't want to? So anyone can refer you to a movement disorders neurologist. So by anyone, I mean any of your physicians, so your family doctor can, other specialists can, a geriatrician can. Usually, I think they wouldn't have a problem with doing that. Sometimes I would say that we do have, unfortunately, long wait lists just because of the burden of referrals relative to the number of specialists in the province. But I think it's helpful if you really want to see a movement disorder specialist that you just need to speak to one of your doctors for a referral.